Thank you so much for joining us for this UW-Madison Department of Obstetrics and Gynecology Healthy Women Community Talk, High Blood Pressure During Pregnancy and Beyond. We're really thrilled that you can be here with us and spend a little time learning about this very common and very complex and interesting condition that can affect a lot of pregnancies and a lot of folks in our state. A couple really quick housekeeping things. We'll ask that you stay on mute unless you're speaking. We will have several breaks throughout the talk for questions and sharing, so there'll be opportunities to share things. If you have questions or think of things and you want to put them in the chat, we've got two awesome outreach specialists who are monitoring the chat to make sure that everything gets addressed. And if you're having any trouble with the presentation or have any questions, feel free to drop them in the chat at any time. We're kind of keeping an eye on that tonight. I am really excited to introduce you all to Dr. Kara Hoppy. She is an incredible maternal fetal medicine specialist in our UW Department of OBGYN. She is an exceptional clinician and an exceptional researcher with a deep interest in hypertension and high blood pressure during pregnancy. She was the lead of the Wisconsin site of the National Chronic Hypertension in Pregnancy Study, which recently changed the game for how high blood pressure is treated during pregnancy. And we're going to get to learn more about that study a little bit later. But Dr. Hoppy is just amazing, and I hope that we can all enjoy learning from her tonight. I will now turn the presentation over to her, and thank you all so much for being here.
Thanks for the warm welcome, and it's a pleasure to be here. So hopefully we can have a little bit of fun throughout the time we have together tonight. We hope it's interactive and enjoyable, and here we go. So we are going to kick it off with a poll. I think it's really important to kind of know what brings us all here tonight. Here we go. You can select multiple choices too, if interested. So we'll give that a couple minutes to collect. In the meantime, what brings me here, I think I can kind of talk a little bit about that. In general, I'm a clinician, but also a researcher. And, every day I just want to make care better for the women and families or other birthing people that we serve. And this is a high impact area that I feel like affects most people, if not yourself, somebody, or a loved one, or family, friend, etc. So I'm really passionate about it, and I really enjoy making things the best I can for the patients I serve. All right, so what brings you here today? I'm here because looks like a tie between I'm not pregnant but planning a future pregnancy. I'm a preeclampsia survivor. Actually, there's a one that's even more important. I work with women at high risk for blood pressure, so that's exciting. We have some providers on the call, and then I'm currently pregnant or recently postpartum and have an interest in learning more about high blood pressure. So exciting. I think we have a little bit for everybody. Before we put this talk together, we also wanted to know what people might be interested in. And so Jackie has a lot of experience with social media and was able to throw out polls through different social media avenues. So we asked, what do you want to know more about? And one of the most common responses we received was the latest blood pressure research, treatment options, and then high blood pressure signs and symptoms, and also how to optimize my health. So again, I think we'll touch on a bit of that, but it was a really exciting way to kind of plan for a talk so we could try to cover what interests people. So we're going to kick things off just with what is blood pressure.
Why do we care about blood pressure? Blood pressure is the force of your blood against the walls of your arteries. Hypertension or high blood pressure is when this force is more than it should be. When blood pressure is high for an extended amount of time, it can cause problems like stroke and organ damage. When the blood pressure measurement is complete, you will see three numbers. The top value of your blood pressure is called systolic blood pressure, which is the pressure in your arteries when your heart beats. The bottom number of your blood pressure is called diastolic blood pressure, which is the pressure in your arteries when your heart is at rest. The third number is your heart's beats per minute.
So I think, a lot of people are familiar with both these words, but high blood pressure or hypertension. And a lot of times these words are used interchangeably, but high blood pressure is simply a measurement that demonstrates the force of blood pushing against the walls of your blood vessels. And that's blood pressure, and then it's high when those pressures are high. So hypertension is more of a long-term medical condition in which that blood pressure in the arteries is persistently elevated. So while hypertension can be identified with constant, persistent elevations of blood pressure. So high blood pressure is more of just simply that measurement, where when that measurement is constantly high, we can think of hypertension. But I bring this up because in a lot of conversations I'll talk with people and they're like, of course, I've been told I have high blood pressure, but I don't have hypertension. So I think that's really important to just kind of start the talk out with an understanding of those two terms. And this is a pretty busy slide, but I really also think it's important to know your numbers. So without having like a resource to look at, it's really hard to know, like, what do these numbers mean and what do I do, with my individual numbers. And so I think I wanted to take a little bit of time to go through this. And when I looked at the American Heart Association and what they were putting out for just patient information, this is the table that they present. So I feel like I owe it to you to give you the same information. And I like that it's labeled sort of green, yellow, orange, and red. So, it's just sort of like a stoplight. Green is go, yellow is sort of take a pause, and red is like, hey, we have a problem. So the upper number reported on those blood pressures is called your systolic, and the lower number reported is your diastolic. And so, as you go across in these different categories, you can look to see about each of those numbers and where your numbers are kind of fitting. And then obviously if you're normal, there's nothing to really do about that. But if it's elevated, or even in that kind of high blood pressure stage 1, that's where we need to start paying attention. And then high blood pressure stage 2 or higher is when we really got a problem and need to do something more quickly. And these are numbers specifically when you're not pregnant. So the next slide, I'm going to talk to you a little bit. The numbers are a bit different and more simplified for pregnancy. So when you're pregnant, we've sort of got 3 categories, and normal is anything less than 140/90. And there's a lot of kind of arguments or sort of dissatisfactions with that. And so I think over the years, we're going to probably see that number be lowered. But when I say normal, it means that we really just don't intervene on behalf of those blood pressures until they're higher than those numbers. And it also gets tricky when you are not pregnant and you have kind of blood pressures that are in that yellow or orangish range that are elevated, but they're not normal. But then you go into a pregnancy, you're like, well, then where do I fit? So we then categorize anybody with blood pressures that have these ranges listed here, which can be decently high blood pressures as mild range, high blood pressure, or hypertension. And when blood pressures get higher than 160 over 110 is where we call it severe. And specifically in pregnancy, I think it's really important that people simply understand if your blood pressure goes over this 140/90, you need to let somebody know. You more than likely won't feel it, but it's not normal and kind of needs to be investigated. And we'll go through, more details, but I just really think, knowing your numbers are important. So if you see them, you kind of know how to respond. Again, going back to just how to manage a diagnosis of hypertension. Again, this is not pregnant, but that stage 1 hypertension is the values that are 130s over 80s or higher. So it's often that your provider is going to just prescribe you lifestyle changes and consider adding medications only if you're at really high risk of these cardiovascular disease risks. Most people in the childbearing age do not have a risk that's high enough. And so again, the most common thing are going to be recommended in that kind of upper level blood pressures are just diet and lifestyle changes. Now, if those things are done and they're not effective, starting on a blood pressure medication may be recommended. And again, that's where it gets tricky then when you're in that range, and then you get pregnant and you're like, they don't care about that anymore. Stage 2, though, is where providers are most likely going to recommend prescribing a blood pressure medication as well as lifestyle changes. So that's over the 140/90. And again, that's where we start kind of caring about those numbers in pregnancy. So if you're running that way non-pregnant, it's very common that you might be on a blood pressure medication to stay less than those numbers when you're pregnant. So moving a little bit to hypertension in pregnancy, believe it or not, 2 out of 100 women have high blood pressure before pregnancy, and that number has been increasing at an alarming rate over the last 20 years, and that the largest increase we've seen is amongst African American or Black women. So how do we recommend preparing for a pregnancy with high blood pressure? So anybody who has chronic hypertension or blood pressure issues before pregnancy, I can just only emphasize enough, see a healthcare provider, and one that's invested in helping you plan and optimize things before you get pregnant. So we want to optimize that blood pressure. We want to keep that blood pressure less than 140/90. And again, if it's diet and lifestyle changes that are recommended, those include things like losing weight, exercising, or managing your diet. When you're on blood pressure medications, there are some medications that are not safe for pregnancy. And so getting yourself on the right medication is important, and being stable on that medication again before you would try to become pregnant. And then understanding your risks, having this condition, and then your overall goals for pregnancy, and being on the same page with that healthcare provider. So now, during a pregnancy, we asked again on social media and asked for people to share stories or questions. And so we received this story. Severe preeclampsia during my first pregnancy, was diagnosed at 33 weeks and I was induced at 34 weeks. Happened so fast. And this is really important because a lot of people are just trucking along, they're doing fine. They really have no idea that, they're at risk of preeclampsia, and really it can affect anybody, and it really does happen fast. And so it's a scary thing when we're not watching out for it. And one of the takeaways for today is to try to give you some of those warning signs and ways to advocate for yourself so we can catch it early and improve outcomes. So types of blood pressure in pregnancy, we could get into the weeds really quickly. So there's sort of an overarching term that we will use called hypertension disorders of pregnancy. And we are really having high rates of this in Wisconsin. So 20% of our pregnancies, or 1 in 5 birthing people, have a hypertension disorder of pregnancy. That number is a bit lower nationwide, 12%, but still very common. And that could be the chronic hypertension we're talking about. So the people who know they have elevated blood pressures or on medications before they become pregnant. And then there's pregnancy specific conditions. So people who've never had any high blood pressure problems, they simply have elevated blood pressures during their pregnancy with no evidence that any of the other body organs are affected. To get a diagnosis of preeclampsia, again, we have sort of this increasing spectrum of severity where your blood pressures are elevated, but now you're showing signs that your other organs are affected. So specifically, we see that the kidneys are starting to spill protein. And there's a large variation in just very mild range blood pressures, mild symptoms, but that can turn into more of a severe picture that include things like seizures or liver dysfunction, brain dysfunction, strokes, etc. And then there's a really critical syndrome called HELP syndrome, where we start seeing the liver enzymes get really high, and we see the platelets, which are the clotting factors in your blood, get really low, as well as kind of the constellation of other symptoms associated with severe preeclampsia. So again, it's really complicated, and when you talk to people, they have a variety of all of these, but I sort of think of them all as very important and all causing increased risk and problems to our birthing people in Wisconsin. I just sort of talked about this a little bit, but preeclampsia is a condition that occurs only in pregnancy, and it can sometimes pop up in the postpartum period and has effects to both the mother and the unborn baby. and it's affecting at least 5 to 8% of all pregnancies nationwide. And it can be a rapidly progressive condition that, like I mentioned, includes high blood pressure and the presence of protein in the urine. So some of the things that you'll see throughout the slide are really excellent resources from the Preeclampsia Foundation. And actually at the hospital I work at, which is Union Point Health Meriter, we will give these handouts for people birthing there. But preeclampsia, again, the what is it, risks to you, risks to your baby, what should you do, and signs or symptoms. And the slides coming will talk a bit more about this, but I like giving resources to people as well. So a community question that we received was, if I have preeclampsia in one pregnancy, how likely is it to happen again? So research suggests a 20% chance of having preeclampsia in future pregnancies. Sometimes that number is quoted higher, and in the specifics of that, the more severe you have of a case of preeclampsia, that recurrence rate might be higher, or if you had a really early preterm preeclampsia, et cetera. But that's sort of a general suggestion. Working with your doctor and healthcare team, it is possible to have a safe and healthy pregnancy after preeclampsia. And so I really encourage people, to reach out to their providers and work with your care team, to figure out how that could be managed, and maybe not avoided if that's something that's really important to you in your future. So preeclampsia risk factors. This is sort of a long list, but if people are out there kind of thinking about becoming pregnant or trying to figure out, like, am I at risk? Well, honestly, everybody's at risk, but people who might have an even more elevated risk would be people who have had a history of preeclampsia, you're pregnant with more than one baby at one given time, having history of chronic conditions like hypertension, type 1 or 2 diabetes, chronic kidney disease, having had an organ transplant, that it's your first pregnancy, obesity with a BMI over 30, being of older age, over 35, but also younger age folks too, so under the age of 20. And also thinking about family history. So not, we all have a decent idea about family history, but not everyone really is aware to ask their family members if they had preeclampsia. Polycystic ovarian syndrome, lupus or other autoimmune conditions, actually having in vitro fertilization or IVF to conceive, sickle cell disease, and then Black or African American race. So I tried to put together a little slide here that says, what are the expectations of the medical care that you should expect to receive while you're pregnant, given a diagnosis of underlying chronic hypertension versus a new diagnosis of preeclampsia. And you could kind of throw in any of those, like, hypertension disorders of pregnancy as well there. But with a chronic condition, when you come in, you're going to end up with a baseline assessment. So if you haven't already worked preconception with somebody, baseline laboratory tests are really important, and they're important to understand where you start the pregnancy, because if you end up with preeclampsia, like I mentioned, some of those organs might be affected or labs might change, and we want to know where they started to compare. We'll often get some cardiac function testing, so an EKG or heart ultrasound. The longer you have hypertension, your vessels may function different, and so you might be starting at a different baseline with your heart function. It's going to be really important to understand where your blood pressures are, knowing your numbers, and treating with medications. And I'll talk to you about the CHAP study that Jackie alluded to, but really important to have optimal blood pressure control. I'll touch a little bit on it, but aspirin is a newer medical therapy used to lower the risk for preeclampsia. So if nobody talks to you about taking aspirin, you really should be taking a baby aspirin, and the dose is 81 milligrams. So I like to make sure that people are aware that they should take that. And then in the pregnancy, you're at higher risk of having growth problems for the baby, as well as stillbirth and other complications. And so we do extra testing to make sure the baby's growing well and that the heartbeat's looking great through that 3rd trimester. And with preeclampsia, one of the reasons prenatal visits get more frequent at the end of the pregnancy is because we're watching for preeclampsia. And so you're already going to be having frequent appointments at that point, and oftentimes that's where they find that your blood pressures have gone up. But if you have a diagnosis of new hypertension in your pregnancy, you'll have more frequent evaluations, laboratory assessments, oftentimes weekly if you're outpatient. Sometimes you need to stay in the hospital overnight or until you deliver. The possible need for blood pressure medications to take care of your hypertension. And if anybody on the call wants to know more about management of blood pressures, in the hospital or something before birth, I'm happy to address it. But there's a special medication called magnesium sulfate, which is an IV medication. And the purpose of it is to prevent people from getting the seizures that can be associated with preeclampsia. And so there's a lot of restrictions around your care on that medication, like you can't drink a lot, you can't eat a lot. After birth, people are often unaware that you're on it for about 24 hours before you can come off. It doesn't make you feel the best. However, it's very morbid to have a seizure. And so it is one of the standard care mechanisms for people who have really high blood pressures and preeclampsia in their birthing period. And then sometimes babies are born early or need to have a preterm birth. There's no treatment for preeclampsia. And so when it gets out of control, the only treatment really is delivery. And I like to throw in there, increased risk of cesarean section. Sometimes we just can't get a woman delivered early enough, or the baby's not tolerating that delivery. And so just gives you a little bit of an idea of what to expect if you were to have one of these conditions in your pregnancy. And then, as I mentioned, this is risky business for both the mom and baby. And so on the mother side, I addressed some of these already, but you might need to be admitted early in the hospital. You might need to be induced for your labor or have a cesarean section. You might end up having preeclampsia, like I talked about, and other associated cardiovascular heart complications like stroke, and even in very severe cases, death, which is terrifying. But hopefully not something that people have if we really advocate for the patient and teach people how to advocate for themselves. And then baby, preterm birth, being small and needing to be admitted to the neonatal intensive care unit are common things to consider. So this is an important slide. So symptoms of new or worsening hypertension. I want to exclamation point that the most common thing is that people really won't have symptoms, but if you should experience any of these symptoms, new onset severe headaches, seeing spots in your vision, having shortness of breath or difficulty breathing, pain in the right upper side of your abdomen, which is specifically where the liver is. And so the liver can kind of get swollen and stretch, and that causes pain. A feeling of nauseousness or wanting to throw up that doesn't really make sense, and swelling in your hands or face. So this is where we wanted to take a bit of a pause, but you are your best advocate, and we would just really want to emphasize knowing your own body. And if something doesn't feel right to you, to contact your healthcare provider or go in and be seen. There's so many stories that people are like, well, my appointment's tomorrow, or I just didn't know, or I wish I would have known this. And so we just wanted to ask, what have you learned from your own experiences that might help empower others, that might be experiencing anything that we've talked about so far. We just respectfully ask that you don't bring up specifics about providers or hospitals, but we really would like to hear from the people on the call.
And hi, Dr. Hoppy. Are we taking a little break for questions right now?
Yeah, I mean, anyone can put anything in the chat if they want to share something.
Well, we have two questions. The first question is from Jacqueline, and her question is, why are measurement ranges for blood pressure different during pregnancy than when you're not pregnant?
Well, that's just an excellent question. So I'm going to touch on it a little bit towards the end of the pregnancy, but really a lot of it is that I'm meaning the world of obstetrics, care providers, we just didn't have enough evidence, and we were worried that if you overtreated one's blood pressure, the baby would end up small. So the blood pressure ranges are different because also when kind of the original hypertension classification occurred, American Heart Association actually still use 140/90 as hypertension, and it's in more recent years where they've lowered it and found the benefit in non-pregnant people to lower it to that 130/80 range. And, and then arguably, like, if you're doing diet and lifestyle changes at that threshold, well, in pregnancy, it's more of a focus on like when you're going to intervene on behalf of something, and all of the preeclampsia definitions are 140/90, and I think that's just not being discussed about changing. Where more of the discussions are is like, what do you do when someone's now has hypertension because of that stage 1 level, and then like how do you manage that differently in pregnancy, because it's like not really there. So I think we're just knowing like people whose blood pressures are more elevated, they have higher risk of having, worsening problems or complications. And so again, it's a more of like, noticing that risk and being on top of it earlier. But yeah, there's just not been demonstrated benefit in the past without concern for the baby to actually not treat until people were like 160/110. And we've recently changed that. So we now very much do something at 140/90 for people with chronic disease. And it's also tricky because it's like an acute limited blood pressure problem in pregnancy rather than like a chronic issue. So again, a lot of it's just lack of knowledge, lack of understanding, and trying to balance risks to mom and baby. And so I hope that makes sense.
Thanks, Dr. Hoppy.
Welcome.
There's
more-
another, oh,
Yeah.
sorry, go ahead.
No, I think you're going to talk about the other one in the chat.
Yep, there's another question in the chat from Anne. When dealing with postpartum hypertension and weaning down medication, does it stall out during the process, or should the blood pressure still stay super low?
I don't know if I quite get the question. We want the blood pressures postpartum at least to stay less than 140/90. And so I would just say that a lot of blood pressures spike after people go home. And again, they don't really feel it, but that's where a lot of morbid events are happening to mothers. So we want to control those blood pressures. And I think the question's asking about weaning down the medications. Does it stall out? I just don't quite get that second part. I'm happy to have you come off mute if you want me to kind of detail that out or understand better. I also will say I don't think the blood pressure can go low enough. I mean, if people's blood pressures are 90s/50s or, at a place where they're symptomatic or lightheaded, I think that's a reasonable, obviously we should lower blood pressure medications, but other than that, people usually tolerate their blood pressures. I think a great place to be would be 120/80. And just to kind of add to Christina's question here, how long after birth are patients at risk for postpartum preeclampsia? What I experience, and I run like a pretty robust postpartum monitoring program, and I've cared for thousands of people, so we have lots of data to like answer that question. People are really at risk through 6 weeks postpartum, but the most high risk periods that we have problems are between days 4 to 14 postpartum, and those blood pressures are really an issue right when you leave the hospital. And so it's deceiving when you birth your baby, because within those first 3 days, the blood pressures really are pretty quiet. And it's really kind of the minute you leave in those first few days home, where if you're actually paying attention to them, they can get quite high. So I think that the highest risk is really between 4 and 14 days, but can last much longer. We typically say 6 weeks, but we have probably like 30% of our patients who still have high blood pressure at 6 weeks, and they may need to take 12 weeks or months before their blood pressure is actually normalized. All right, well, thank you for those questions. Keep putting them up there if there are other things. So here, my blood pressure started out at 124/90 on a lower dose of beta-lol. It started dropping to 80s/70s before they lowered a dose a second time. Am I going to be stuck on meds forever? I see. So I think when blood pressures are that low and you're getting close to that end point of your postpartum period, I would personally recommend trying to wean off that medication more. And if people can get off their medications and stay less than 120/80, no, people should not need to be on meds forever. But the true answer is that when you have a new hypertension issue in pregnancy, you are at long-term risk of developing hypertension. So some people will not be able to get off their meds. Thank you for helping add to that story. So people wanted to hear about latest research to improve health for women with high blood pressure. So I have a few areas that I wanted to touch on. So there was just a big trial. You may have seen some of this on the news or in the newspapers, but this is like really the hottest topic and most exciting thing I feel like that's happened in obstetrics for a really long time. So CHAP was a trial called Chronic Hypertension in Pregnancy. This research, the goal was to improve health for women who had high blood pressure before pregnancy or chronic hypertension. It was conducted at a lot of centers across the country, and we enrolled like around 2,500 women. And Meriter was a site for that as well. So before the study, the problem was, as I sort of already mentioned, is that pregnant women weren't recommended to receive the same care as non-pregnant people for their high blood pressure. And actually to the point that people were not treated for their blood pressures unless the blood pressures were severe, so over 160, over 110. And what we did for that trial was we, like as a flip of a coin, randomized people to either be in that group where we didn't treat them until they had severe range blood pressures, or we started them on medications to keep their blood pressures less than 140/90 the whole pregnancy. And what we found in that study was that actually prescribing medications to women who had mild high blood pressure, that 140 to 160 over 190 to 110, had improved health outcomes for the mom, as well as did not have any compromising effects to the baby. And those health benefits were really important. So reducing the risk of preeclampsia, reducing the risk of preterm birth, reducing the risk of placental abruption and death. And why is this important? So if you or a loved one have high blood pressure during your pregnancy, you can expect now, like, hope that there's something to do with your blood pressures that actually might improve your pregnancy. And you should talk to your doctor about actually starting on medications to keep your blood pressures less than 140/90 or staying on your blood pressure medication. So many people are told to stop their blood pressure medications. That's kept them stable. And we're no longer recommending that. And this study was reported in April, and like literally overnight, the recommendations changed nationally, and ACOG's behind it, Society of Maternal Fetal Medicine. So it's just like a revolutionary change for our pregnant folks. I wanted to talk about preeclampsia prevention, and I could put and list a bunch of studies, but it is the only thing we have for preeclampsia prevention that's been shown to have some risk reduction. So I typically recommend for my patients to start on a baby aspirin around 12 to 14 weeks. We think it has we don't really know how aspirin works, but we think it has something to do with improving the placenta and how it develops in the early stages. And actually, without getting too detailed, preeclampsia is thought to be a result somewhat of having problems with how the placenta established itself in the pregnancy. So at this point, the United States is primarily recommending a dose of 81 milligrams. Countries outside of the United States are using 150 milligrams, and we don't actually have that dose in the US. I took a look at the data in the recent past and kind of pooled a bunch of studies, and what it showed was that at a higher dose, which we would have to use 162 milligrams or 2 baby aspirins in our country, but that the risk of people who had it the risk reduction in people for developing severe preterm preeclampsia was like 60%, or 6 out of 10 chances, versus using the 81 milligram dose. It didn't really matter for term preeclampsia or kind of later onset preeclampsia, the dose you used. So again, you're most commonly going to be told to take 81 milligrams. And I also showed that list of people who are at risk. So even if you've not had preeclampsia before and have any of those risk factors, or a couple kind of more lower level risk factors, you should be on a baby aspirin. So honestly, most people qualify to take a baby aspirin. So I just want to mention that because there's a lot of people I see who still haven't been told to take it. Staying healthy after childbirth, we call it STACK. So this is a program that I created and have been working on since around 2016 or so. And I've done a lot of different research and investigation. I have an excellent team of nurses and medical assistants at this point, a lot of support from UniPoint Health Meritor to make it possible. But what we basically do is we have all the postpartum, patients who are delivering at our hospital sign up to receive a home tablet and a blood pressure device where we collect blood pressures every day when you leave the hospital. So these questions about like, if I'm on medication, when do I stop my medication? Like what's going to happen when I go home? And what if I need medication? Like we take care of all of that. So we see all the numbers and we recommend, dose adjustments or starting medications, and we'll call that prescription in. And we've just really standardized it as an institution. And so everybody receives pretty consistent care. It works really well. We've been able to reduce the need to go back in the hospital or be readmitted, which is amazing because then moms and families are together rather than separated. And then once people need to go down on their medications, we help with that. We help connect and refer people back to a primary care provider if their blood pressures are still high. And also, just as we're doing today, we want resources out there for everyone to access. So through this website, there's a healthy choices section, there's a resource section, there's the same videos we're showing you about blood pressure and how to take your blood pressure, common questions people might ask. So hopefully this is a growing website that is around for a long time that we can just continue to make better, but it's a bit of my own personal research and touch to this topic. So after delivery, again, here's a sheet from the Preeclampsia Foundation. Again, we talked a little bit there. I do believe they have magnets, and also even like printing these off and just putting them up as reminders, but it is still something that can happen after delivery. So postpartum preeclampsia is the topic here. Symptoms, again, are similar, what you should do, warning signs, etc. So there are also risks beyond pregnancy. So I mentioned this a little bit, but having a history of preeclampsia places people at higher long-term risk of not only high blood pressures, but heart disease, chronic kidney disease, strokes, diabetes, venous thromboembolism, which is a blood clot in your legs or your chest, most commonly, vascular dementia. And so there's just this definite long-term increased risk of cardiovascular problems, complications, and death in our folks who've had hypertension issues in pregnancy. So a community question: what are the long-term issues related to preeclampsia, and what should I look for as I age? So this is just a graphic that's made and adapted from the paper with the reference below. But those who'd had preeclampsia and gestational hypertension, just showing you that there's increased risks of most of the things I just talked about: hypertension, cardiovascular disease, ischemic heart disease, stroke, heart failure, and diabetes. So as you age, it's very important to engage with primary care and healthcare prevention, because all of those are known associated risk factors that if we don't do something about your health, may be things that women experience. Let's see here. So postpartum care is super essential. So the postpartum checkup is really important for moms and ongoing care. One cool thing we do with our STACK program is that moms don't have to go in for blood pressure checks because we're watching them from home. And the reality is that 60% of patients, actually up to 60% of patients, don't even come to a postpartum check at all. So finding ways to really engage with healthcare providers postpartum is really important. Additionally, when we find people have persistent hypertension at the end of 6 weeks and we refer them, What I'm finding at Merida is like a third of the people will actually schedule these appointments and less of them go to these appointments. And these are appointments with a primary care doctor that would hopefully help reduce these long-term cardiovascular risks that I'm talking about. And so we need to do better. We need to make sure our healthcare system puts into place measures to optimize postpartum health for our moms and families, and figure out what barriers exist, and really try to get people, the follow-up they need to really reduce their long-term risks. And there are some tools to help us out. So again, these are from the Preeclampsia Foundation, and I found out about them recently, and actually we're giving them to all of our postpartum moms, but I just think it's a nice thing to have. And there's 5 pages. The first 2 pages here are just your information, your baby's information, and what specific disorder did you have in your pregnancy, or what did your baby experience as a result, talking and reminding you about these increased risks that are associated with having had hypertension during your pregnancy. And then really emphasizing what to do about these things postpartum. So there's a BMI or body mass index tracker, and spots here for you to fill in, your blood pressure at 6 weeks, 6 months, and 12 months. And really, I would encourage people to take these into a healthcare provider, to show these and track these, or work with your healthcare provider on those key landmark times postpartum, and then making a plan on how to improve your health. So aiming for your blood pressure below 130/80, get moving and exercising. Like I said, see your primary for frequent checkups, lowering your body mass index as possible. And even thinking about future pregnancies, any weight you can reduce or normalize your weight to are going to really improve your outcomes in a subsequent pregnancy. Learning how to eat healthier, live smoke free, sleeping, figuring out how you can sleep adequately. And like I said, make an appointment with your healthcare provider and plan for that next pregnancy. And there's one more page. So this would be the ideal checkup at 12 months, that you go in and you get these labs done, and make sure that you're not developing any of these chronic conditions that may be something that you would experience. And again, those things should likely happen every month, on a frequent basis, like every year after that. So again, just a slight tool that you can find at the website listed here, but to maybe help empower you in kind of your journey after one of these conditions.
I'm wondering if we could get to a couple of questions before this video. There's a couple of questions that came in this postpartum section. So Cheryl, if you want to start those.
Anne has 2 questions, Dr. Hoppy. The first one is, why does postpartum hypertension happen if the placenta is gone?
That's a really good question. And I think if we knew the answer completely on a scientific level, we'd be light years ahead. But all I can say is that there's residual, changes that happen in your pregnancy that are just not gone until, weeks or months later. And so whatever it is that's triggering, preeclampsia to happen is likely, like I said, lingering on, and the body needs time to recover. There's also normal changes in the blood pressure when you get pregnant and after. And so when you start a pregnancy, your vascular system remodels, you have way more blood volume in your body, and you're adapting to that placenta that's there and the pregnancy that's there. So it takes time for all those hemodynamic and physical changes to recover, even when the placenta is gone. But I think it's an important question in the sense that most people are told, well, you have to have the placenta removed to get preeclampsia to recover. And that's true, but it's not immediate. And when you're in the hospital those first 2-3 days, your blood pressures look better and people think they're cured. And then the problem is it's just this salient missed thing that it's really not gone, and you're still at risk further on in that postpartum period. So I don't have a direct answer, but hopefully that's kind of helpful.
And Anne has another question. Do those future risks exist if you only have had hypertension without the preeclampsia features like liver, etc.?
Yes. So it is true.
Okay, we have a question from Christina. Has there been any research on preeclampsia and its relationship to postpartum anxiety? I found seeing the high blood pressure numbers and being told the risks, stroke, etc., cause some, cause some anxiety, some increased stress with previously being healthy without any chronic conditions.
That is such an important question. And I think, Anne follows up kind of validating that. So in one of the projects I have, I actually, heard from a lot of people about the social support they need and kind of learning to deal with the trauma that might be associated with a complicated delivery like this, or, not having issues in the past and now having problems. And I've really tried to create like a group that people could come to postpartum, actually moderated by a real therapist, and really to have peer support. And I just haven't been able to like navigate people to get there. But, and I talk a lot with, also other people, other survivors, the Pre-Eclampsia Foundation, and learning how to like funnel that stress into a productive way is very important. Whether that's, learning how to be an advocate for this topic, learning how to take control over things for yourself. I think all of those things are very important. But postpartum depression alone is common. And when you have something like this happen, anxiety and depression are a lot higher. And I've even had extreme situations where honestly, I'll have patients come. I had one patient, it was so severe that she couldn't even like have a clinic blood pressure because she like became very obsessed with her blood pressures actually postpartum, and would check an innumerable amount of times in a day. And so I think, I can only say in like the program we run, we try to take that off the patient and try to provide productive solutions in a quick fashion. But I think a lot of people probably feel alone and don't know, and then they don't know what to do long term. So I think we need to do better for our patients, acknowledging this, finding ways to support people. And if it's still a lingering thing, I think one of the best places I know is just, there's a lot of advocacy stuff that goes on with the Preeclampsia Foundation. I have a lot more I could say on that topic. So I hope I did a little bit of it justice with that question, because it's a really important point to make. You're not alone. Anything else that we want to do with that chatting at this moment?
We're caught up on the questions.
Okay, I think we wanted to just show you like a standard way to take your blood pressure. So if someone tells you to go home and take your blood pressure, at least you have an idea of how that should be done.
Knowing how to take your blood pressure correctly is important to ensure an accurate reading. Accurate readings start with using the right size blood pressure cuff for you. Wrap a tape measure around the middle of your upper arm, halfway between the shoulder and elbow, to measure the circumference of your arm. The measurement you get will tell you what size cuff is correct for you. Most recent national guidelines suggest that the most accurate way to take your blood pressure is at home in your own environment. If you are on blood pressure medications, please time your blood pressure reading to be about 60 to 90 minutes after your morning dose. That value can help your healthcare team ensure correct dosing of any blood pressure medications and decide if medications need to be increased or decreased. In the 30 minutes before you take your blood pressure, do not exercise, eat a large meal, or use products containing caffeine or nicotine, such as coffee, tea, or cigarettes. Prior to sitting down to take your blood pressure, you should empty your bladder. Sit at a table, such as a dining room table, on a chair with your feet flat on the floor and your legs uncrossed. Place your blood pressure cuff on your left arm, as this arm is usually more accurate. The cuff should be on your skin without any clothing in between the cuff and your arm, and should be just above the bend of your elbow. It should be snug around your arm, but not too tight. Your arm should be rested on the table at about the level of your heart, with your palm facing up. Do not tense your arm or take your blood pressure while feeling anxious. Leave your arm relaxed and rested on the table, and make sure to rest for 5 to 10 minutes quietly prior to taking your blood pressure. Using your device, follow the prompts to start your blood pressure machine. The cuff should inflate and deflate to measure your blood pressure. Your environment should be quiet. Any noise can raise your blood pressure and can give an inaccurate value. Do not talk, text, or watch TV while taking your blood pressure. Take slow, deep breaths. To ensure accuracy, make sure to take 2 blood pressures during the same sitting, about 1 minute apart. When the blood pressure measurement is complete, you will see 3 numbers. The top value of your blood pressure is called systolic blood pressure, which is the pressure in your arteries when your heart beats. The bottom number of your blood pressure is called diastolic blood pressure, which is the pressure in your arteries when your heart is at rest. The third number is your heart's beats per minute. Please seek medical attention if your measurements are concerning, or if you experience any signs or symptoms of preeclampsia. Those signs could include severe headache, seeing spots or other visual changes, shortness of breath, pain in the upper right side of your abdomen, feeling nauseous or throwing up, or swelling in your hands or face.
This here is a tip sheet. So just a kind of reminder of things to do. It can be a lot to take all this in and then have to go home and remember how to take your blood pressure and not have any of the things going on that we say not to do. But it's really important that you have good hygiene around it, just because, imagine your cuff size is wrong, or you're having a lot of coffee and then your blood pressures are high, and then you have unnecessary intervention when it could be avoided. This is also on our website. And then this is just a call out. So beyond pregnancy, that was on the Pre-Eclampsia Foundation for Preeclampsia Awareness Month, but schedule your annual visit with your primary care provider. And I think, being a woman myself and having a family, it's really hard to remember to do things for myself and to take care of the general things we need to take care of for ourselves. But the best you can do, don't wait 5 years to the next pregnancy, and then find out there's a problem in those 5 years that you could have maybe done something about. So just stay in touch and advocate for yourself. So again, we had another discussion break, and we wanted to know if anybody wanted to share a pregnancy experience. If anyone had any further questions about high blood pressure, hypertension, or how it affects pregnancy and outcomes. We did have a couple of community share comments that are listed here. I had severe preeclampsia during labor. After I was discharged from home with my son, I did my morning reading or blood pressure as usual, and suddenly it was very high. I was really panicked. Thankfully, because I had the telehealth home support network, I was able to get the treatment I needed, bring my blood pressure down, all without leaving my home. So this is just, exclamation point. It is a panic moment, and people are scared. I had gestational hypertension with both my kiddos. Shout out to the telehealth nurses. And with that, I was greatly appreciative of the great information I was given during my second pregnancy and how management of my blood pressure would look to help keep me and my baby safe. So just a couple of those to share, but I think we kind of wanted to see if anyone else wanted to share, and then I don't know, just have to do the talking.
Dr. Hoppy, there was
Yeah.
a question from Nicole, and her question is, excuse me, would staying on a low dose of aspirin after childbirth reduce risk of postpartum hypertension?
That's a great question. So there are long-term side effects of staying on aspirin. I think you're asking just about postpartum. I don't think we know the answer to that specifically, but the current kind of guidelines are to stop it after you when you go in to have your baby. I think that we think it works mostly probably, with placental health and development when the placenta is there. So the long-term risk of taking aspirin would be things like gastrointestinal bleeds, or if you fell or something like that. And so I've asked the experts in, the cardiovascular field if we should have our moms after birth take aspirin forever. And the answer they told me was no, because the risk of having a complication was higher than their lifetime risk, at that young age of having an event. So currently we're not recommending it after the pregnancy.
We have a question from Anne, and just to remind people, if you'd like to unmute yourself, there's a little microphone at the bottom left-hand side of your screen, and you can just click on that and unmute yourself. So Anne's question is, how much does anxiety affect the numbers? I'm anxious all the time and the medication makes it worse. Could my diastolic 90 number be for my anxiety, or does anxiety only raise it minimally? I feel panic a lot.
That's a good question. So I would say I think anxiety does play a part in some people's blood pressures. Everybody's baseline blood pressure is a bit different. But what I do find that the trickiest is that, when you're calm, hopefully in the morning or at a calm period of day, you take your blood pressure, it's decent, and you repeat it once, it's reasonable. If you're asked to take it again because it's high, most of the time, it comes down. But there are times where people just get really anxious and they take lots and lots and lots of blood pressures. And what we see, especially in that first couple of weeks, is that those blood pressures throughout the day just get higher and higher and higher and higher. The thing about it is you have to wait also for medication to work. So if it's treated, the worst thing to do is test your blood pressure all day long. You take the medication, you just have to have trust that it's working and wait, 12 to 24 hours for it to take effect, and check the blood pressure the next day. And it's most typically just fine. So that's one thing we've learned. And I do see, Kristen Hildebrandt is on the call, and she's one of our staff nurses who's really supported a lot of patients, and she might have some insight to this. But what I also want to say is that there's a condition called white coat hypertension, which we think, when people go to clinic and you're like, oh, my blood pressure is always high in clinic, anxiety probably plays a part in that. And there's a lot that I do with patients in that situation, and there's some options there. One is that always sit and wait for 5 minutes before anyone takes your blood pressures, because those numbers typically will come down. Some people have a real hard time with a provider taking their blood pressures. So sometimes I have the provider actually exit the room and let the patient take the blood pressure themselves. And then the other thing that we've learned a lot in just general medicine is that actually blood pressures at home are way more predictive of one's blood pressure than any clinical value taken, probably because of anxiety and other components that go into having high blood pressure in those situations. So the answer is yes, but usually there's a calming way to take that component out. And I think if those numbers are constantly, like a diastolic's constantly over 90 in your home when you're calm, it's probably a real value. I see a comment about panic and deep breathing. I think that's excellent. Anybody else have anything that they want to share before we kind of get into our last little section? Even anything that anybody wished they would have known, that they might want to share with somebody else on this conference tonight. Okay, well, our chat's open, but one question we had, for everybody was, if you could design a better system, what would it include? So what's missing? What should we build? What would be helpful to support patients in the community? What resources would you like to have access to? And so we're going to open up this poll, and you can, again, select multiple things. But this is for you all. So whatever you think would be really helpful to know. When Jackie gets enough, I think she'll pop up the results for us. We have a lot of work to do, it looks like, everybody. There is a comment in the box about better mental health support. I hear you. And the biggest barrier I have is like how to get people there. Would it be best served immediately postpartum at 6 weeks, 12 weeks? It just seems real tricky to help people get what they need postpartum. That's an excellent comment too. Just resources for sleeping and how sleep deprivation can affect blood pressures. Absolutely right. Do people have any thoughts about if they'd rather like meet as a peer support group or with individual support? If anyone has any thoughts, maybe you can throw that in the chat. Okay. Well, with that, I think we would all like to thank you for coming. There is a big event, September 10th, 2022, 11 a.m. at the Badger Prairie Park. The Promise Walk is a fundraiser for the Preeclampsia Foundation. It's a great place to meet a lot of people, survivors, families, people in the community that are supporting everybody. Get out and do some exercise. You can create a team. You can help raise money, or you can just go and be part of it. So we're doing this community kind of pep talk, just kind of also to bring awareness to, preeclampsia and, resources for everybody. So wanted you to know about that. I want to also especially thank Melody and Jackie and Cheryl to help me pull this off tonight. I hope everybody's found some benefit. Be happy to do this again someday if people liked it. If anybody has any other closing thoughts, questions, concerns, we'd be happy to take anything.
As people maybe think if they have another question or two we want to sneak in, because we've got a little bit more time yet. I just wanted to mention Melody's been peppering links in the chat throughout, and we've got the video resources and everything. And I will follow up. You will get an email from the same account that sent you the link for this in the next few days. That'll have a link to tonight's video and then links to all of the resources that we've shared tonight. So no need to stress about copying them out of the chat or making sure you still have them. We will make sure that the workbook from Pre-Eclampsia Foundation, links to videos, anything supportive that we've shared during the talk will also come straight to your email, so you can save it for later. Oh, and a feedback survey, which we would really love to hear your thoughts on tonight, and if you have interest in other topics or future topics. So we want these talks to meet our community needs, and we'd really love to hear kind of what you're thinking and how we can continue to help share resources and be useful.
Absolutely.
Okay.
I hope we've met the goals for everybody here, and everybody, with all the different backgrounds and purposes of being here tonight found a sliver of it, of something that I helped, fulfill.
I definitely feel like I've learned a lot.
Anything else, Melody, Cheryl, Jackie, you want to bring up or address?
Just want to thank everyone for joining us, and if anyone thinks of any questions, they can I think we had contact information in our emails. They can send us additional questions in addition to the things Jackie mentioned. We'll be sending. We're happy to answer questions as they come up.
Absolutely.
Thank you so much.
All right. Thank you so much, Dr. Hoppy, and thank you so much, everyone, for being here. This was really wonderful.
You're welcome. I hope everyone has a great night.